Hi, well, I can confirm we are streaming on YouTube now, so all right to proceed. Thank you.
Lovely, thank you, Lucy, and good afternoon, everybody. Delighted to welcome you all. It's actually to my first meeting of Coventry and Warwickshire Integrated Board meeting in public. We are transmitting this meeting live on YouTube, so members of the public can observe us, and we will be making the recording available as well for view subsequently if people would like to catch up with it. I'm really pleased to be chairing this meeting today. It is as I said, my first meeting as chair. We are obviously going through something of a process of change. So when we meet again in January, we'll be operating as a clustered board for working with Herefordshire and Worcestershire Integrated Care Board. But for the purpose of the public, we will be obviously focusing on all the key issues that we consider are really important for our community in Coventry and Warwickshire, and that will remain our ongoing focus. I'd like to welcome a couple of people for the first time who are joining this meeting, specifically Russell Hardy, who is chair of Swift and George Eliot, and Sue Noyes, who is chair of UHCW. So just wanted to welcome them as participants. Also wanted to welcome Hannah Taylor, who's part of Herefordshire and Worcestershire ICB, but who has been working with colleagues, Mark and others, in just looking at how we will establish our joint governance arrangements. I know we have apologies from Ellie Monkhouse, and also pleased that Jamie Soden is here in her place today. So welcome, Jamie. A couple of other things really to mention. We do have apologies from Pam Bradbury, who is one of our non-executive members, and Dr. Terry Eaton, who is one of our GP partner members. I want to take the opportunity to say thank you to both of them in their absence and to record our thanks as a board, because they are Pam is moving on to a new role, so she won't be a member of the board in January, and Dr. Eaton is standing down. But also to say a huge thanks to people who are also present but are moving on for various reasons. Harry Hayer, one of our non-executives, Kevin Davis, Maddie Palmer as our CFO. Maddie will be moving to a new role. So I believe that this is going to be the last formal board meeting for colleagues, but I just want to, on behalf of Coventry and Warwickshire Integrated Care Board and the community, really thank colleagues who've been made such a big contribution to the success of the board, and indeed also to Mark Gwynn. Mark, I think this might be your last board meeting as well, so just wanted to thank you for your contributions. I think that's all the meeting management items that I wanted to cover. I'll look to Mark and Hannah to let me know if I've missed anything out. Otherwise, I think we can get on with the business of the board and move on to first and foremost, I'm aware that we're quorate, so I think we can confirm that. And just double check that, are there any declarations of interest in relation to items on the agenda? We do have obviously declarations recorded in a statement, but if there are any specific items in relation to the agenda today, it would be useful to note. Okay, I'll take that as none, so thank you very much. We move on then to the action log. There are no actions outstanding as I understand it, so we'll just note that. The next item that requires formal approval is the minutes of the meeting held on the 17th of September. So I look to colleagues to confirm that they're content that the minutes are an accurate representation of that meeting. Everyone content? Thank you. We will approve those. Okay, so moving on to the substantial items on our agenda, we have our patient and public voice section. We have no questions from members of the public. I always like to take the opportunity to remind members of the public they are most welcome to submit questions, which we will try and respond to if they relate to items on our agenda. So always delighted to welcome those, but in the absence of those, I will hand over to Dr. Imogen Staveley. Imogen is our CMO and Chief Medical Officer for members of the public. Imogen, you're going to share a citizen story for us. Thank you.
Thanks, Krishni. So this is a patient narrative about a care home resident with dementia and complex needs. The patient is a 66-year-old woman with a 3-year history of vascular dementia and a 10-year history of chronic obstructive pulmonary airways disease, COPD. Previously an active teacher, the patient's only close family are a sister and a brother, the latter of whom also had early onset dementia and has since passed away. Over the past 2 years, the patient has been in and out of various care settings with significant behavioural and psychological symptoms of dementia, including paranoia and wandering, leading to a deprivation of liberties order in 2023. The patient's journey through the care system began with this initial admission to a care home in 2023, which was short-lived due to frequent falls and behavioural issues. The patient then came to the attention of the Coventry geriatric team after being admitted to hospital following falls in October 2024. After a period in hospital when they had an inpatient fall, the patient was discharged to a form of sheltered accommodation. This arrangement quickly broke down due to further falls, resulting in another hospital admission at George Eliot Hospital. After she absconded from A&E, her home declined to allow her back due to the risk of absconding. During the 2-month hospital stay, the patient required one-to-one observation, support from dementia nurses and experienced inpatient falls teams. Subsequently, the patient was discharged to their current care setting, a residential home in March 25, where they have remained since. Over the last 12 months, the patient has had 21 attendances at the emergency care department with falls and undergone 19 CT head scans, with only one scan revealing acute pathology, a periorbital fracture that was managed conservatively. The remainder of the scans did not reveal any new information or alter the patient's management. Upon meeting the patient in September as part of the community geriatrics pilot, it was noted that the patient had a diagnosis of postural hypertension, causing blood pressure to drop upon standing and contributing to ongoing falls. Medication adjustments were made, including weaning off drugs that worsen that low blood pressure and titrating the drugs that were needed, which provided some improvement but did not eliminate falls. A respect form was completed in agreement with the care home manager, GP, and the patient's sister, stating that the patient should not be admitted to hospital for falls unless there was a suspected fracture or bleeding requiring intervention, as she was not a candidate for or would tolerate any invasive interventions or restrictions. Despite this, a fall occurred 2 days later, resulting in a head injury. The care home followed the care plan and did not initially contact the paramedics, but after 6 hours, they had some concerns about the patient being drowsy, which led to them contacting the ambulance service to ask for an assessment. Paramedics attended the patient and took the clinical decision to override the care plan and conveyed the patient to hospital. The patient was admitted to hospital for 48 hours and was then discharged with no treatment. Following these 48 hours in hospital, the patient's mobility and paranoia noticeably worsened. A best interest meeting was convened with the multidisciplinary team, including the patient's sister, geriatric consultant, social worker and care staff. It was agreed that moving the patient to a nursing home would be beneficial, as falls had occurred in every care setting, even with one-to-one care, and the patient was settled at their current location. The patient's advanced dementia and need to remain active was acknowledged, and it was recognised that further falls were likely inevitable. The team agreed that if the patient were to suffer a terminal injury or infection, management should focus on end-of-life care within the care home, avoiding hospital admission whenever possible. The patient's prognosis is estimated at around 12 months, but could be shorter in the event of a sudden injury or infection. After the best interest meeting on the 17th of October, the patient was admitted again on the 21st of October following another fall. Following this fall, the care home manager had concerns about a rib deformity and contacted the OCIT, who were unable to attend. This led to an ambulance being called. The patient was again admitted to hospital for 48 hours before being discharged with no changes made to her management. Efforts have been made to improve care coordination, including involving the high dependency paramedic team and developing a care plan to reduce unnecessary hospital admissions. However, challenges remain, ensuring that all relevant information is communicated effectively to paramedics and care staff, particularly during out-of-hours incidents or when agency staff are involved. The patient's sister, who lives in Cornwall, has expressed frustration at being contacted by paramedics for decisions about hospital conveyance, feeling unqualified to make such judgments. She's also described distressing experience of the patient in emergency departments, including long waits and increased confusion and paranoia after hospital visits. Her sister did note, however, that after the last hospital stay, when the patient was cared for on the acute frailty unit and turned around quickly in view of previous discussions, she was much more settled and happy on her return. Being managed in a quieter area, being offered meals, and someone having time to support her in her individual needs really helped reduce the trauma of attending hospital and meant her confusion and behaviour were not worsened on discharge. The case is an example of the challenges and systemic issues in providing integrated person-centred urgent care for individuals with complex needs. It highlights the human cost of repeated hospital admissions and the importance of focusing on quality of life and appropriate approach to urgent care for patients with advanced dementia. Later, you will have the spotlight on urgent emergency care paper. This patient story gives some colour to the challenges faced by patients and clinicians. It shows the challenges of working across silos and interpretation of guidance and plans when under pressure. Patients like this are often termed high-intensity users, and not only do they have a difficult set of experiences, but they utilise huge system resource. There is hopeful work going on to improve outcomes for patients like these and to make better use of resource. For example, the Community Geriatrics Pilot, which is a team of consultant geriatricians who are working with care homes to put plans in place for patients like these to prevent unnecessary trips to hospitals. Furthermore, the Clinical Executive Group in Coventry and Warwickshire is also doing a piece of improvement work around the use of CT head scans in patients who are frail and who have fallen. They are linking this with regional and national NHS England work and doing an audit with full patient records across the system to inform local actions. There is buy-in from this not only from health but also local authority and other partners. This type of stewardship is the first phase of work, with ideas being considered for the next steps thereafter to be led by the clinical teams. Thank you.
Thank you very much, Imogen, for that. It really does highlight a lot of opportunities for improving the care and for the patient, most importantly, but also to make our services more joined up and more straightforward for people to access. Are there any questions or comments that colleagues would like to bring up? Chris, please.
Thank you. It's a comment rather than a question, but I also draw on my own experience with my elderly mother, who's 94, doesn't have dementia, but many common issues here. And I do believe that when we think a lot of the health services is structured around a curative model, and of course, what we see as we get older is a predisposition, a weakness to multiple conditions, and you look at the challenges of obviously transporting patients, whether it's family or whether it's in non-emergency transport, the immobility that comes with being in hospital, the loss of confidence quickly and everything. It really is a reminder for us, I think, in terms of the way we're designing our neighbourhood services and the work that's going on to really maximise everything we can do to support people as well as possible outside of hospital, but particularly the older members of our population. So, thank you, Chris. Mary?
Thank you, Chair. So, two reflections. The first being, I didn't hear a sense of how this lady's care was linked to any of the services provided by CWPT. I'm thinking there's work supporting care homes by an in-reach service, or even just thinking about the old age psychiatry sort of services, but I don't know to what extent they were involved. And then I suppose a reflection for me around actually calling people high intensity users, and I know it's a term that's used here, there, and everywhere. Actually, I find it unhelpful and perhaps gives a label that doesn't really sort of touch on the personalized bit. You end up being a high intensity user rather than a person who may be presenting with whatever needs. So I suppose it's a just reflection to ourselves to sort of think about how we may be calling people with those sort of needs, and we may need multiple services to support them.
Thanks, Mary. Imogen, do you want to comment on the access to sort of dementia, I think CWPT services, which Mary touched on, and I do agree with you, Mary. It's a term that we use frequently, or have used, and is recognised in the NHS, but it doesn't sound a particularly compassionate term, is it? And so it is one of those things that we probably do need to reflect on. But I do recognise it is a common phrase that is used. Imogen, your perspectives on those 2 points?
No problem. So as you'd expect, Chair, we've slightly shortened the story to make it appropriate broad. We haven't gone to every team member that's been involved. Of course, I think the community geriatricians in this service is incorporating holistically all the services that are required. I will go back after this to absolutely double check that with this patient, but I think it's more that it's a simplification for board the story rather than it as excluding any particular partners, and I'm sure it is drawing that in, but to make sure. But I will double check that learning is incorporated into this case.
Thanks, Imogen. I was struck by how many interventions, just in sheer sort of numbers of interventions, whether it's scans or assessments, that the individual, our citizen, had experienced. And I'm not a I'm a non-clinical person, but it did strike me that there is I wondered how much there is in our, how clinicians kind of think about somebody with that set of needs, and whether actually these interventions over whatever period of time, so many, is that really helpful? Is that really adding value? Because I'm always struck by the Muir Gray kind of feedback about the amount of wasted interventions we do, which are not actually in the benefit of the individual that we might have in front of us. So Imogen, appreciate your thoughts on that.
Yeah, so I completely agree, Krishni. I think that what clinicians do in the moment is try and make the best decisions in the moment, looking at the patient in front of them. But what we're hoping the clinical executive group does is help clinicians to consider resource more broadly about the patient population and look at holistically at the patient in front of them, not just that particular care episode. I think we've got opportunity with improved digitisation and shared records to be able to look at different people's records. We've also got learning, so things like what has been learnt by the community geriatrician team is to put respect information that is about the family discussions that have taken place, as well as the complex multidisciplinary team. So that would bring in Mary's point about all the team members that have been involved in that patient's care, to put that all into the respect form, so that when a new paramedic comes that doesn't know anything about the case, they're able to see the complexity, all the partners that have been informed, made the decision, as well as the family's engagement in that decision making. So that's one bit of learning that has already happened. But what we want to do as a clinical executive is, we know that there's nice guidance about CT head scans in patients that have fallen, but those nice guidance are written with a point in time. They're not looking at a specific patient, it's guidance. One of the reasons we're clinicians is to be able to interpret guidance and not follow it to the letter. What we're hoping is that by creating some what is accepted culture of practice in Coventry and Warwickshire, where we look holistically, do shared decision making with our patients and their families to work out what's best for the patient, that I personally don't believe 19 CT head scans for an individual patient of that, like with that prognosis in the last year of life, is the right thing for anybody. And it not only could cause harm to that patient for the experience they have to go through waiting for those scans and having those results interpreted, but also it's taking that resource away from other patients that could be used for other things. So that is very much why the clinical executive team is looking to really target. That's going to be our first point of action. It was really powerful in our clinical executive meeting when we discussed it, when one of our urgent and emergency care colleagues pulled up the patients in the 6-bedded UEC majors area of UHCW, and 3 out of 6 patients in that bed were waiting for CT scans, and all of them had had at least 1 scan within the last 12 months. So what we need to allow for is safe use of CTs if it's appropriate, but if it's just automatically being done because a frail person has fallen without any thought about the we're all taught about like the GCS, which is looking at the conscious level, looking at any signs or symptoms that would suggest there's been damage to somebody's head. We want to begin to think more thoughtfully about that, and most importantly, shared decision making, holistic management of those patients.
Absolutely. And there is something about, I think, sharing with the public the importance of keeping people as well as possible at home and supporting people at home. I will just share briefly that I have a doctor in my family, and I had a frail elderly mother who has passed away now some time ago, but he was always of the view that hospital was the last place that she needed to be. So actually we were educated by that, and we would work really hard to with clinicians who were supporting her to try and keep her at home as much as possible, because it actually added to her confusion when she went into hospital. So I think there's something about everybody kind of understanding the risks, particularly for frail elderly people, of being in hospital for any extended length of time. And this story really reinforces that, I think. I'll bring Suki in and Imogen give you the final word afterwards. Suki? Oh, we can't hear you, Suki.
I think it highlights having those difficult conversations with sort of the patient and their families. I think often as medics we can be quite reactive, and wanting to sort of problem solve. And often it is about managing the patient holistically, and managing risk. And I think it highlights that often we don't get communication between primary care, secondary care room, and the community life. And often you'll be sort of seeing an out-of-hours doctor who obviously doesn't know the patients. And it's how we make the process smooth for the patient and their family, because I think end-of-life care is one of those pathways that we need to ensure that we're getting right.
Yeah, absolutely. Thank you, Suki. Imogen, back to you finally.
So just 2 final points. One is the opportunity that integrated neighbourhood health teams bring in this space. Krishni, as you mentioned, keeping people well at home, there's a huge opportunity for that in this space. And the other thing is, it's not just clinicians in this, so it's the helicopter cover we give our clinicians. So I suppose I'm speaking to the chief execs in the room and others from the partner organisations of how we support our clinicians to feel safe making some of these more difficult decisions, because clinicians are worried about their own licenses, and often, unfortunately, if a decisions made that has an unfortunate outcome, it comes to that individual clinician. So something about how they're supported by their organisations and how we use all the relevant latest like CQC, GMC guidance in supporting clinicians, that shared decision making will be supported by those people.
Yeah, really important. Thank you, Imogen, and really thank you for sharing the story and for giving us an opportunity to reflect on that and think about the learning we can draw from that, which I suspect we'll come back to a little bit as we progress through the meeting, and particularly when we come on to our item on urgent emergency care. Okay, we move on then to the Chief Executive's report. So Simon, over to you for paper 3.1.
Thank you, Krishni. Good afternoon, everybody. And thank you to colleagues from the exec team that have helped to pull this together. This is designed to provide a bit of a helicopter overview for the board, really, of the big issues, the big things that are happening in the system. And there's a lot going on, I think, will be my conclusion, actually, and it's a struggle to fit it all in, to be totally honest. Hopefully people have had a chance to have a good read of the report, but if I could just pull out 4 things in particular, I suspect people could do with further information on. Firstly, the ICB change process, and we talked about this when I was with you in Rugby at the last meeting. It is really accelerating now, and this is very real for colleagues in particular. We are nearing the end of a consultation process on a new executive director and director structure. The transition committee has guided me through that, but we've got a week or two left, I think now, week and a half left on the consultation process. We are proposing a structure that has 19 roles. There are 36 people who are affected, so 36 people will turn into 19 roles. Interestingly and importantly, I think, and it's mentioned in the report as well, the operating model we've proposed and the structure fits very nicely and very neatly with the strategic commissioning framework that's been published in the last few weeks by NHS England of the role they want ICBs to play. So I'm quite confident that we have a good alignment between the direction of travel that we are heading in. Another couple of points on transition. So firstly, we are now, it's not in the paper because it only came to light at the end of last week, but we have been awarded some national funding and permission to run a voluntary redundancy scheme, which opened on Monday of this week and will run for the next few weeks, and we'll see. I'm expecting a reasonable amount of interest from colleagues who will reflect on what role, if any, they might want to play in this new type of organisation across the new geography as well, moving forward. So we've launched that scheme. We'll reflect on the outcomes of that early in the new calendar year, and then we'll be looking to move through the rest of the organisation, probably layer by layer, but also probably driven by gaps, because I suspect we won't have a nice, even, equal spread of people asking for voluntary redundancy. There will be concentrations in particular teams and particular gaps, therefore, that we need to fill. So all of that is really going to accelerate this change process that we are well and truly in now, for sure. Elsewhere in the paper, I put some performance headlines in that Rachel's helped me with. We are going to do an urgent care spotlight in the next agenda item, and obviously a lot of the performance information is also covered in the quality performance, finance and workforce section later on the agenda. But I think it adds flavour to the report because it provides a really good context of the outcomes that we are hitting. Specifically for Coventry and Warwickshire, there's a couple of items in there around mental health and learning disabilities and the direction of travel strategically. So firstly, working with Mary's team and her trust around how we can get a little bit more trust ownership of the Section 117, decision making, patient interaction and resource management really as well, which I think is a really important step forward. Clearly she'll be looking to work closely with Becky and Pete and teams within that, because Section 117 packages involve a split of funding contribution from the NHS and the local authority. And then secondly, and related to that, I know you've discussed previously this year around a direction of travel for lead provider for mental health and learning disabilities. I still think that's the direction of travel we want to go in. I see real opportunities, but I do think working across a cluster provides a slightly different perspective on that. So what we're looking to do is we'll pursue the Section 117, and then there'll be conversations with the board, with the new board post January, with Mary and with colleagues in Herefordshire and Worcestershire, and around how we can take a more strategic cluster-wide approach to that really as well. And probably the final item from the report I'd pick out is on page 9, which is the local government reform agenda, which is particularly relevant in Warwickshire. Similarly, actually, to Worcestershire, which also has a two-tier local government system, a county council and district and borough councils. The government's direction of travel is they will all become unitary authorities over the coming years. Lots of conversation, lots of political debate actually over the course of the summer months. Two proposals are emerging for Warwickshire. One, which is to have a single Warwickshire unitary authority covering the whole council, and there's a separate proposal that's been put forward which would split Warwickshire into two, a North Warwickshire unitary authority and a South Warwickshire unitary authority. So I and some colleagues have been involved in some of the stakeholder conversations about that. I have represented some views into that process on behalf of the NHS, really based on trying to protect our staff, and particularly operational staff, from potentially doubling the demands and doubling the complexity. So It won't be our decision to make. It's not even a local decision to make. It's something that ministers will decide. And the decision actually, I don't think, will be known until probably after Easter, summertime next year. But it's really important strategically for the system just how that plays out. It's not an issue in Coventry because Coventry is already a unitary authority, already clearly part of a combined authority in the West Midlands, but a really big issue in Warwickshire, and similarly in Worcestershire and Gloucestershire and some of our other neighbouring counties as well. So Krishni, I'll probably stop there in terms of introduction, but very happy to take any questions on any of the items in the paper.
Great, thank you, Simon. Harry, please.
Yes, thank you. Well, first of all, Christian, thank you for the very kind words that you said at the beginning of the meeting. Yeah, so I will be leaving at the end of this calendar year, but I did want to say that I spent my formative years in Coventry, and I still have family in Coventry and Warwickshire. So growing up in Woodend, Foleshill and Holbrook have made the person I am today, I think. So it's been a real privilege to serve this population. So thank you to colleagues for the support that you've given me in this role. Simon, turning to your really clear paper, thank you. I was just going to start with local government reform. You've already clarified it in what you've just said, but the paper, given it is in the public domain, talked about Warwickshire County Council leading on the development of a proposal to create a single unitary council that covers all of Worcestershire. I know that it's meant to be Warwickshire. I didn't think that Warwickshire County Council had reach into a different county, but thought I ought to just mention that just to correct the public record. My just two final points really were about, if I just turn to them now, sorry, just bear with me. We're about sort of equity and diversity and inclusion, and it would be really just to encourage executive colleagues and their teams to not only rely on the data on how disabled colleagues in the ICB and those from minority ethnic groups feel about working here, but actually spend time listening to their stories and their experiences, because it's often that rich contextual stuff that can only be captured through conversations than through data. So it's great that we're making progress, but I would really urge some sort of personal contact around that agenda rather than just the reports. And I did just want to point out again, it's just a public record thing, because I don't know if anyone spotted it, because I was a bit thrown by it, but Felicity very kindly corrected me. So and it's on page it's on your last page, Simon. So it says the second paragraph down, the training improved the likelihood of non-white colleagues being appointed from shortlisting from 1.9 to 0.11. To me, it looked like the figures weren't quite right, but Felicity's explained that is absolutely right, and it's just the way in which those numbers work. So just in case somebody had read it and thought that sentence doesn't quite make sense by way of the numbers, it is factually correct. So thank you.
Yeah, Christian, I'll come back on. I mean, firstly, thank you for pointing out the typo. Your colleague Chris Hurst beat you to it on Monday in pointing that out. And hopefully Rory amended the version that was online by Monday evening. So we're hoping nobody else has spotted it, but clearly we're going to have to get up earlier, aren't we, Harry, if we're going to make a mistake and for you not to spot it. On the couple of points, look, I totally agree with you. I've had a lot of experience we've done some reverse mentoring in the past that I've been part of. That was one of the most useful things I've done. I think it's a really good reminder, particularly at a time of change, to really have your listening head on, to be able to hear what it's like for people. You know, I'm trying really hard to be as visible as I can in Coventry and Warwickshire, to be in the office, to be with partners, and that's going to be critical, I think, over the coming months. But it's really important, isn't it, in the equality and diversity agenda? I would agree. And yeah, Felicity had explained to me, which it's a useful opportunity to clarify. So the figures you refer to, the reduction from 1.92 to 0.11. So if the figure was 1, that means that non-white and white people would have an equal chance of being appointed. The figure last year was 1.92, which meant Non-white colleagues had much less of a chance of being appointed. The figure this year is 0.11, which meant non-white colleagues actually were much more likely to be appointed as part of shortlisting. So it is a good story, but you're right, they're just headline numbers, aren't they? This doesn't tell the full story of what it's like to work here, and I know that part of your legacy will be the focus that we need to keep on this, particularly in the workforce space. So thank you for raising that, Harry.
Any other comments or questions? I've got plenty, Simon. You know that you won't escape my my clarifications on the report. But actually, I mean, I did want to commend colleagues on that improvement, because that is significant, you know, to go from 1.92 to 0.11. But Harry's point and your point, Simon, is really important, that at a time of change, it's very easy to undo that progress, so it's really important that we keep our focus, because I think historically, I'm sure that there is a statistic Felicity might be aware of. I don't know what the exact data is, but I'm pretty sure there is a sort of narrative that when the NHS goes through change, it becomes less diverse. And I'm pretty sure that's been the case in every single restructuring that the NHS has ever experienced. So I think if that is the case, you know, it just highlights the importance of us not undoing the really strong work we've done. I can see Felicity nodding, so I don't think I got that wrong. So thank you, Felicity. Couple of things that I just wanted to explore a little bit further, Simon. I wondered if you could say more about the ADHD emergency policy and what our plans are to review that, particularly in light of, I'm aware that there's been a task force that's been working on ADHD, and that has just recently reported with some new recommendations, which happened to come to my attention. I'm not asking anyone to comment on those, but I think it is just about recognising that this is a national challenge and there are things that we all need to do to address that. So I wondered if you could comment further on that or ask colleagues to do so. The other area was just around the Section 117 and the lead provider arrangements, which, you know, I'm very supportive of and have a sort of strong interest in. I think it's just important for us as an ICB to understand, and with our provider colleagues, whenever we're looking at these, is what processes we have for joint readiness assessments that give us confidence that this is the right thing to do from a board perspective, because I guess we still remain accountable for much of this, and also what are we clear what outcomes we're going to try and improve, because I think that the change to strategic commissioning needs to be very much about improving, you know, accountability for improving outcomes for our population. So have we got some thinking around that we're developing around those arrangements? So maybe Simon, you may want to start or hand over to other colleagues.
Yeah, no, I'll happily start, and starting with the latter one first. That's really important. I think we're on a bit of a journey, aren't we, with lead provider and delegation. I think this applies not only to the work we'll do with Mary and teams for mental health and learning disabilities. I think it applies to the next chapters of the journey for care collaboratives as well, that we always need to keep an eye on. Well, where are the measurements and metrics? How are we going to know whether this is making a difference, whether this is working or not? How are we going to know which bits are working, maybe which bits aren't? So I fully intend, both in those discussions we'll have around Section 117 and mental health, but also the care collaboratives, we're going to put a bit more structure and a bit more of a framework around it, so that there are clearer measurements, and that will definitely be the story of 2026 for these things. In terms of ADHD, I'm going to bring in Imogen, if I can, who's leading this, but certainly this was one of quite a bold step I think the board took last year. I think we took a good decision for all the right reasons. It was only ever intended to be temporary. So this is something we're reviewing and we are looking to change at the end of the financial year. But Imogen, do you want to add any more flavour on that?
So I think, Krishna, you specifically asked about the national task force. So our transformation group locally that has been working on this since the policy came in is really aligned and keeping close to what that national task force has been reporting on. In fact, we have, one of our clinical leads that works between the ICB and CWPT has links into that at times. So we're trying to keep as close as possible. We are looking to utilise digital solutions, primary care, shared decision-making models, and then increasing capacity at CWPT for the most complex patients, so those that have got coexisting things like mental health problems as well as their neurodiversity. We're looking at phasing it, so what we will do, we need to do enough to lift the policy of changing the pathways enough, but we're looking at a longer term, a sort of medium term plan about looking at neurodiversity in a whole, so looking at autism and ADHD in together. At the moment they often wait a long time for one of those diagnosis pathways and then have to wait again for another. So we're looking at how we can work together with local authority, etc., to improve on that. I hope that helps.
And thank you very much. No, that's really helpful, and appreciate I'm coming to some of this very fresh, so I hope the questions are helpful just in clarifying things. Well, certainly are from my perspective, but also perhaps for members of the public as well. So thank you, Simon, for the report. Thank you to colleagues who supported Simon in putting that together. I think you're just asking us to note that at this stage, Simon.
Becky has got a hand. Becky has got a hand up.
Oh, sorry, Becky. I omitted to spot you there. Becky, please come in.
Sorry, I was a little bit late. I just wanted to pick up in the report, which is really clear and really helpful, around the strategic commissioning framework, and I suppose just noting, given everything that's going on with colleagues in the ICB, there's a lot to do by March in terms of building on some of the things that we have around the commissioning plan, the population health improvement plan, the neighbourhood health plans, and the baseline assessments. I suppose it was just recognising that that's a lot to do, and an offer of support, particularly from our kind of JSNA and commissioning colleagues to support with that.
Thank you, Becky. Thank you, Becky. I hesitate. I did ask Simon that question earlier in a different setting, so I thought I would see if somebody else, and I'm very glad you asked that question because I felt it was an important question, and Simon, you may want to respond to that. And thank you for the offer of support as well.
Yeah, I mean, I'd start by saying we are really grateful for partners' support, and actually I do think the specific bit you mentioned, Becky, around the whole population health management approach, how we get much closer liaison between the public health intelligence teams and how that's feeding into that process is really important. I think we may have lost some of that over the last 6 or 7 years. It's a great opportunity to reset that. And I think on the wider point, look, the change agenda is huge, and we've got to deliver winter. It's really, really busy, isn't it? Operational colleagues from the trust will tell us it's really busy out there. We've got a difficult flu season that we're in the middle of. Demand is high. We've got planning to do. We've got a series of pretty high profile political waiting list reduction targets and other things to deliver. There's a lot of change. I don't think for a second that it'll be sorted out and done by the 1st of April. I think this is a journey we're going to be on. We will look to accelerate the pace for sure. We'll look to get as much help as we can, and we'll try and take people with us. I think that's the critical bit. Both our staff and our partners need to be on this journey with the ICB to make it something that we all feel we've got a stake in. But it's going to take a good year, I suspect, to really get where we need to be, particularly in terms of some of the internal changes we're doing. But look, I'm really grateful for the support, Becky, and thank you for drawing that out.
Thank you. So thanks, Simon. We'll note that report and move on then to the Spotlight on Urgent Emergency Care, which is item 4 on our agenda. And delighted to hand over to Rachel. I think, Rachel, you're going to be involving Laura and Ali in this, so I'll let you manage that item and we'll come back in for questions and comments. Thank you.
Thank you, Krishni, and good afternoon, everybody. In just introducing this item, I'm conscious this is the 3rd time we're bringing UEC to the board in quite a recent period. So I'm going to take the paper as read, Obviously, we can pull out some of that later on, but we've pulled a few slides together just to highlight the points that we think are worth prompting in terms of discussion. And to Krishni's point, recognising that the responsibility for UEC transformation now sits with the care collaboratives, I'll do a couple of slides that present the overview of the current demand in the system, and then Laura and Ali are going to do a couple of slides to describe some of the work the care collaboratives are doing, both in the short term but also the medium to long term, in transforming those services to try and improve the outcomes for both our population and our patients. So first slide, please, Rory. I mean, this detail is in the paper, but we just thought it was helpful to highlight the current demand. So if you look at the first chart, this is with regards to A&E performance and demand. So you can see a 3-year comparison of attendances across all 3 trusts, recognising that currently October is only a forecast position. And actually, overall, it demonstrates there is actually limited growth in UEC attendances across acute providers from this year, from April to October. I'll come on to some of the devil in the detail in a moment. So marginal change really this year. And modest growth is also predicted for October. So all 3 providers are currently below their year-to-date expected activity levels. That said, George Eliot have seen a 1.5% reduction in total attendances. Swift are also showing a slight reduction, but you'll see between 23-24 and 24-25, they did see quite an increase in attendances. And certainly we are seeing on certain single days, there is quite significant surge in demand, which is often less visible in the aggregated data. So we thought it was helpful to point it out, but it does create notable operational pressures. And we've also got the UHCW data there, but I'm sure Andy will be the first one, and Sue, to say that there are still some issues with the EPR system implementation. So we're not totally convinced that that data is 100% accurate, but it does give a sense of trend. So that's A&E. If we go on to the next slide, please, Rory. So in terms of ambulances and primary care, we have seen an increase in 999 call volumes across the system compared to last year, with the most significant rise being in that hear and treat category. So those are patients that are then usually diverted through clinical triage to either a GP, a UTC appointment or NHS, but they do come through a 999 route. And that hear and treat activity has actually grown by 10%. So there's a good piece of work going on to actually divert patients away from actual conveyancing. So what we're seeing, as you see from the tables, is conveyancing to hospitals has actually fallen slightly year on year, demonstrating that gradual shift to managing patients either in the community or into alternative approaches. And the care collaboratives have been instrumental in some of that, particularly working closely with WMAS. GP out of hours activities also shown a reduction in total contacts compared to the same time last year. And we are seeing the base visits just slightly increase, but actually advice and home visits has reduced. And we are associating that with the work that Ali and the team have done on the enhanced access to primary care. So we are seeing an increase of almost 10% in that enhanced access provision, which we're seeing an impact in terms of then how that actually flows through into GP out of hours, which is good. I'll hand over to Ali now, who's going to talk about some of the things they've been doing to affect some of that. Or Laura, actually, Laura's going to go first. Apologies.
Thanks, Rachel. If we could go on to the next slide. So I think this year for winter, what we tried to do is kind of bottom-up approach. So went out to our places to understand where are we seeing the pressures and what the population needs. So both from a Coventry and Warwickshire perspective. That allowed us to focus on areas where we see challenge, which are detailed in the paper, particularly around vaccination schemes, a range of primary care schemes, so linked to extended access and cover due to workforce constraints, and alongside our normal acute winter schemes and supporting mental health schemes. What isn't on this slide is also a site to VCFSE support, so a small amount of funding was agreed that actually could we explore what they could offer from a winter perspective. In addition to that, we've also got quite a robust mechanism for kind of tracking and seeing that impact, which I think goes on to the previous discussion around we do all these schemes, but actually what are the outcomes or the benefits for the population? So for each of those schemes, they are tracked to say what do we expect the outcome and impact to our population to be, and that's tracked through a winter touchpoint meeting and then feeds into our urgent and emergency care board. The other piece around winter that we did kind of in the spring and summer was we looked at the risks held at place and actually started to consider, well, if we're holding that level of risk within the places across Coventry and Warwickshire, what do we need to do differently to mitigate the UEC risks? Whereas previously we've just had one overarching risk with detail that was very much held by the acute. So very much a partnership approach with a range of schemes across all of our partners that will work through collectively. Next slide, please. So in terms of the short to medium term opportunities, last November we brought a range of stakeholders and partners together to look at what are our quick wins in terms of urgent emergency care provision and what are the things that we want to focus on in terms of priorities. I'm not going to go through all of these in detail, but these were the themes that came out around how do we maximise kind of our commissioning and contracting opportunities in these services, which I think you can see the benefits from what Rachel has just alluded to. So our urgent community response teams and access to them through our single point of access. We've recently mobilised a discharge group that again is collating those themes around discharge escalations rather than on the day escalations for individual patients, so that we can really start to get into the detail and understand what we need to do to improve that. And a range of different discussions around patient transport services and how we're all utilising different contracts and funding streams around patient transport. So that's been quite an interesting piece of work, and how do we maximise our current contract whilst exploring potential future opportunities. And then a specific piece around mental health. And we actually did a focus session at our UEC board yesterday around some of those winter schemes, but also alignment to kind of neighbourhood health approaches and crisis assessment centre. So that was really well supported from, again, a range of stakeholders. I'll hand over to Ali now to talk through kind of the medium to longer term pieces.
Thank you. So if you just go on to the next slide. Yes, so our longer term priority, as we've mentioned before, is around that integrated urgent care programme that we've established. We're partway through that programme now, so the from an ICB strategic commissioning side, the Matrix team have pulled together sort of looking at what are the key aims and considerations that the integrated urgent care programme needs to address based on our challenges in our current urgent care system, and that's that whole system across sort of right from sort of the ones, but all the access to all those services that we've mentioned. So the key aims you can see there are around commissioning that integrated urgent care piece in a single approach, so that we're not commissioning inside sort of siloed services, that we pull that together to create that more efficient and effective service for patients and reduce duplication. And improve our patient outcomes, which is what this is all about. To achieve that, the review's been guided by those following considerations. So that shared vision, so that common system-wide vision of what we want for our integrated urgent care model, including understanding the patient's needs within that, need for seamless pathways. Using that local needs analysis, so our population health data, demographic trends, activity trends, etc. And then looking at those integrated pathways and how they collaboratively work together. So the first phase has been completed now by the ICB of that strategic approach, and identified sort of the needs assessment, some key requirements, the beginning of the understanding of what the outcomes were. The next phase then is predominantly will be led by the care collaboratives, working with the local partners, communities and patients to really pick up the needs analysis that the ICBs complete, but also apply that local partnership approach and understanding to it, and that will then inform the design then of that integrated delivery model. Obviously then the next stage will then be for the ICB then to consider the commissioning and contracting approach required to commission that integrated urgent care. Thank you.
Thanks, Ali. That was all we were going to present today, Krishni. Obviously, the details in the paper, I wasn't going to go through section by section of the paper because people have had the opportunity to look at that, and happy to take any questions or any comments.
Lovely. Thank you, Rachel. And thank you, Ali and Laura as well. So are there any comments or questions that people would like to explore at this stage? Pete, please.
Thanks, Krishni. So I know I'll be involved in it through the Care Collaborative, but just on kind of just to look for a bit of comfort around conflict of interest at this point, where we'll have organisations as part of the collaborative that will be part of the design, who are then likely to also be a bidder if we go down a bidding process in a tender. So just kind of a bit of board assurance really that we've got those conflicts of interest locked down and we won't end up having to exclude people who give their time willingly to the design of the model that then can't provide it.
Yeah, it's a really good point, Pete. I mean, the way that we've designed the programme is that three-phased approach, which is the ICB as the strategic commissioner really being clear about what the population need is, and therefore what services are likely to be in scope, and that's the bit we've completed now. The next stage is for the care collaboratives to work on behalf of the places to potentially look at what the model might be in terms of how you might deliver that. But that all comes back to the strategic commissioner, and then the strategic commissioner makes the decision about the model. It'll be the board, actually, it'll be you as a board that make the decision about what it is exactly that will be in scope, the model that we're looking to go out and procure, the envelope, the cost envelope we're looking to then wrap around that. And it'll be the ICB that goes into the market to actually share that information and go out to full procurement. There will be some market engagement as part of that. So it won't just be the care collaboratives doing that piece of work. There will be a piece of market engagement as well. So it'll be equitable in terms of any provider in the system contributing to that design.
Yeah, thank you.
Thanks, Rachel. Pete, you happy with that?
Yeah, thank you. Thanks, Rachel.
Great. So a couple of things then just probably want to explore, and this might not be for you, Rachel. I'll bring Suki in first, actually. I can see Suki's hand has gone up. Suki?
Really good paper. Thank you for that. I mean, digital integration is highlighted as sort of quite a key challenge, but digital exclusion is also an inequality driver. And I just wanted sort of clarity just about the safeguards in place to ensure that the digital transformation that will be undertaken doesn't leave behind those with low health literacy and sort of limited English or no digital access, because I suppose we've got variation and, you know, real pockets of deprivation and inequality within our system.
Thanks, Suki. Rachel, did you want to come back in on that, or would
Yes,
you need someone else?
I can do, and I'm sure Ali and Laura will be able to give some probably a bit more detail because they're looking at that piece of work. So you're absolutely right, Suki. We need to involve all, be inclusive for all of the population as we do this. There is a digital element to the work that we've been doing in terms of how we actually scope what the requirement is. So that will be included in some of the work the care collaboratives will look at in terms of how the model of care will actually address what you're describing. So it is within the programme of work. Certainly Eddie and Diane Bainham from the ICB have also been part of that. Di sits as on the Matrix team and has been involved in some of that work. But I know the care collaboratives are already doing pieces of work in this area, so it might be worth Laura and Ali just describing how they're actually addressing this across the whole of not just the sort of second part of the urgent and emergency care piece.
Thanks, Rachel. Ali, please.
So it's actually it is a key piece of work that we're doing within Coventry, along with Pete and the local authority colleagues, because it's much broader than just digital exclusion, obviously much broader than just the integrated urgent care. So we're picking it up in both parts. So yes, absolutely, the digital transformation for integrated urgent care, but then the digital exclusion is a huge piece of work that we're doing sort of jointly, and we pick up through both the One Coventry conversations, that partnership that we have, but also the care collaborative work.
And Laura, do you want to add something to that?
Yeah, just assurance to the board that it's a similar approach in terms of Warwickshire, so going through the place level discussions and then feeding into the Warwickshire forum, but definitely have identified and particularly variation in our different places within Warwickshire, and actually how do we mitigate and address that, particularly with the change that we're proposing around integrated urgent care.
Thanks very much, Laura. Suki, you happy that your question's been answered? Yeah, I was just actually going to ask about mental health patients in A&E. I know Laura mentioned that that's been looked at the UEC board. It just so happened to catch my eye. There was a bit of an article about mental health patients spending more than 24 hours in A&E, people with mental illness spending more than 24 hours in A&E. I think almost every acute trust was listed alongside sort of what percentage of patients were in October 2025. Laura, you probably know exactly what article I'm referring to, but it did catch my eye, and I wondered whether we what we're doing, whether actually I did, when I was reading the article, I was thinking, actually, is this real? Because there could be physical health reasons why somebody's in A&E for a period of time, but 24 hours in A&E did sound a lot, and all three of our acute hospitals were mentioned in the list with varying percentages. So Laura, are you able to give some insight into that? As you've got your hand up, I don't know whether you're the right person to answer that.
Yeah, so conscious Mary's on the call, but we had a focus on mental health at our UEC board yesterday to talk through kind of the winter schemes and development of the mental health crisis assessment. Some of the work actually was really well supported. So I believe they've done a pilot scheme in Coventry to do triage at the front door for mental health or those showing in crisis, and actually using the assessment service that they've currently got to manage that. So we had quite a discussion around, well, what does that mean for the whole of Coventry and Warwickshire, and what does that look like? So I believe there are plans to do triage at the front door, the same as you would do for acute triage, and working through closely with partners around, do they need acute support or is it mental health only, and actually how do we access that? And we also then started to talk around, well, what would that look like from a neighbourhood approach, and actually how could we build on that? One of the points that came up was around the transport and how we navigate that because of the spread that we've got in terms of those services, and I think the hub being based within Coventry, but very much is a kind of live topic and debate. But I think the initial pilot at Coventry has seen some great successes and a reduction of those patients within A&Es. It's just how do we scale that across Coventry and Warwickshire would be my take from the discussion yesterday.
Lovely, thanks, Laura. Mary.
Thank you. Thanks, Laura. I guess a couple of things. There is a pilot going on in HCW for children and young people, in particular in emotional distress. I think that went live probably 2 months ago. And you are right. Sometimes you do have an underlying mental health issue, but that may not be the reason why you're presenting an ED. So I guess we just need to be clear, which is the overriding need. And I know there are escalation systems in place for those people who need ongoing care, and I think good liaisons with CWPT from that perspective. I guess There's also, we have seen an increase in demand. There's been an increase, particularly for beds. There's some work being done at the moment to try and establish what proportion of the individuals who are presenting are known to services already, which might point to something different, and how many are not known to services. So again, we can make sure that we've got those targeted approach. I spent I did 2 visits in our local EDs just to get a feel of what it's like for individuals and for staff working in those services. I think it's fair to say, I think once the Crisis Assessment Centre opens, it means people who are in emotional distress, in crisis, particularly I'm thinking about people who are neurodivergent. ED is just not the right environment. I could say it straight away. Actually, we need to divert those individuals to a much more appropriate place. So we're really looking forward to resetting up that Crisis Assessment Centre as a different offer for individuals. And I think people who've been around in the system for a long time are here. There was a mental health A&E some years back. But we need to think of it in the sort of new operating world.
Great, thanks, Mary. Really helpful insights there. Adam?
Thanks, Jack. I thought Mary was going to steal my thunder, but she didn't quite. So at Swift and George Eliot, we have seen a considerable increase in mental health patients in ED, both adult mental health patients and children in crisis, actually. And that is creating significant challenges on the EDs, particularly when there are long bed waits. We've seen 48-hour plus delays, longer in some cases. I think to provide some reassurance, Mary and I met last week and had a conversation about this, and I think there is some more work we can do together. The mental health A&E, I think, is a longer term solution which will be really helpful. But I do think there are some things about the way our acute urgent care teams work and the mental health intervention teams will work, which Mary and I are supporting, which can help there.
Sorry, slow to come off mine. Thank you very much, Adam. Really good to hear that you're looking at those problems together. I mean, you know, it's joint working on these sorts of issues that is really going to help address the challenges that that you know poses, not just for the individuals but for our services and supporting people who may be in distress. Ali.
I think you just said exactly what I was about to say, actually, which is that it's how we work together, isn't it, to do it? And that sort of really, in that longer term piece of work, that need for integration between sort of the acute services and mental health services really comes through for exactly those reasons, and not commissioning sort of individual service, but how we align that and how we align provision by different providers together to make that seamless impact for patients, so that we do see those reductions.
Yeah, absolutely. Thanks very much, Ali, and thanks everyone for their contributions. Mary, did you want to come back in?
Sorry, yeah, I just had a thought. I mean, one of my other reflections following the visit, and I know I saw it in one of the reports, about just how we raise the profile of support via NHS 111 option 2. And not encourage. So there's something about saying to our local population, local people, if you need urgent mental health care, NHS 111 rather than going to ED. It's just really raising that awareness of where else people can get support when they're in crisis, which does not involve going to an ED. And I think you can never over communicate, can you? It just feels like we need to do more of that.
Yeah, no, good, really good point. Thank you, Laura.
Yeah, just on that. So I don't think I mentioned in the winter plan, but there is a comprehensive comms plan, but we've talked very much in the collaborative. It's not necessarily just about communication, but education of the population. So that is a proportion of our winter funding has been used to do that. And we've just taken a plan to Rugby Place as a starting piece around that. So we recognise that that is an opportunity for us also.
Great. Thank you very much. Just one final comment, and it's a general one. I don't know whether Simon or Rachel want to comment on this, but at a recent all chairs event. So literally all chairs across the country, ICB chairs and provider chairs, were convened by Penny Dash maybe a week or a couple of weeks ago. And there was a really strong emphasis on winter. I mean, that won't surprise you, but there was a really strong emphasis on a sort of shared oversight of winter, and that boards need to take a real and collective responsibility for sort of just being not, you know, and I'm always hesitant here because I don't want to in any way infer that we're going to be sort of scrutinising people in a disproportionate way over this. But I think being cited on it and feeling a sense of shared ownership of what's happening and how we respond to the challenges of winter is going to feel really important. And I think it's a clearly important dare I say, political requirement for us to get through this in a you know, for our patients' benefit, but for us collectively as well. So I just wondered how what I wouldn't want us to do as a board is to have this discussion and then not almost talk about winter again as a board until February or January. So I just really wanted to get a sense of how we might, if there are things that we need to do or issues that develop that we need to be cited on, how do we want to keep collectively cited on some of those challenges that they develop and provide support, not to over report on this. So Rachel, I'm kind of looking at you, but Simon might also want to comment. Is there a way of keeping us all up to date with a shared sense of what's happening across the winter period?
Do you want me to go first, Sam? Yeah, so we'll continue to do that. You're absolutely right, Christian. This is one of the most critical periods for the board, particularly around patient outcomes and patient safety. So we'd absolutely want to keep you cited on performance. We'll do that through two mechanisms, I think. So we'll do it through the performance report, which obviously we bring to you. But the other way that it will take place is through the care collaboratives we've agreed, I think, are going to run until March, until we look at the construct of those and care collaborative version 2. So they will continue to be the committees that hold responsibility for the way that winter is playing out. And I think it's their role and ours collectively as an exec team through the performance report to bring that data to you on a monthly basis to make sure that you are cited on some of the risks that the system is holding and what we're doing about mitigating those risks. I don't know whether Simon wants to add to that.
No, I would agree. I think that's a good explanation. And Rachel and I did talk about the UEC spotlight agenda item, and I know because I've been at a couple of the meetings where we've already discussed it as a board, but actually because we're in the middle of winter, because of the things Christian you just referred to about the onus on us having really good understanding of this part of the work, we felt it was important to go ahead. And I think it's been a good discussion, hasn't it, as well? But yeah, we're probably not even halfway through winter, are we yet? It feels a bit bleak some days, but we've got a good few months left to go. It's really important, as Rachel says, that we keep the information flow. And Christian, your offer of actually there may well be board interactions that can help unblock some blockages. We need to bear that in mind as well. I think that's a good challenge.
Great, thank you very much. Good discussion. Really appreciate the opportunity to explore that and get a sense of where we think we are. There's obviously a lot of good work going on and a lot of people working together, which is really for me the important part of this. You know, how we maintain our joint working on this. So thank you everybody for your efforts, and you are now rewarded with a short break, which I think I'm allowed to give you 5 minutes according to the agenda, and we're only a minute behind. So is 5 minutes sufficient to grab a cup of tea? Just a reminder that we are on live stream, so perhaps if you want to turn your camera off and certainly turn your microphone off, that might be helpful. See you shortly in about 5 minutes. Thanks. Okay. Double check we've got most people back. So Rachel, I think it's back to you, isn't it, for the next report? I just want to make sure we've got most people back before we make a start. Lovely. Right, so we are moving on then to the system performance and risks part of the agenda, and we have a overview paper on quality, performance, finance and workforce, and it's over to Rachel, but I think, Rachel, there are probably other people who may want to comment on that, but I'll hand over to you to start.
Thank you, Krishni. Yeah, this is for those that haven't seen this report before, this is a 4-element report, and as you've described, Krishni, so we will do a bit of an act. I'll do performance, Jamie's going to lead out on quality, Maddie will do finance, and then Felicity will pick up workforce. For those, as I say, I haven't seen it, it's an exception-based report. So it outlines progress against our standards, our operational targets and the quality areas that we are keen to try and ensure we deliver. It's clear to say that the F&P committee do this in a lot of detail. So the areas that we want to highlight to you, particularly as board members today, are those exceptional areas. The only other thing I wanted to just point out is that there are a number of ICB programme boards, which also include regional tiering calls, which offer oversight of the performance and some of the quality elements to this. So there's a number of areas that actually support us in this. So the first thing to say is the provider NOF segmentation scores came out in September. We've put within the paper the relevant scores for all of the organisations, and all of them individually are working on improvement plans to try and increase those scores. We are expecting new scores out next month, so we hope to see some improvement in terms of the scores that the providers were initially allocated. I won't go into a lot of detail about performance in UEC because I think we've done quite a good debate on that. So in terms of elective recovery, our overall waiting list fell, recognising that this is August data, but we are continuing to see that currently. So in August we were just under 129,000 patients, which is 2.5% below our planning trajectory. And that included 3,200 patients waiting more than 52 weeks for their treatment. Again, there's an awful lot of work going on across all 3 acute providers to try and actively bring that down. And in August, 29 of those patients were waiting over 65 weeks for their treatment. Since then, there's an awful lot of focus been put on 65 weeks and trying to reach the target by the 21st of December that has been set nationally. Providers are confident that we will achieve that. Swift are already there. They already have no 65 weekers. We had 1 patient this month in George Eliot, which was a bit of a shame, wasn't it, Adam? But we couldn't help that. And then UH have brought theirs down quite significantly. They had 13 this month. And having spoken to Cara, the Chief Operating Officer yesterday, they're confident they have plans in place to try and deliver the national target. In terms of cancer, FDS, we didn't meet the target in August. Unfortunately, we're at 72% against a 78.5% trajectory, but all 3 trusts have been doing quite a lot of work through the tiering regime, and performance rose quite significantly in October. So we are seeing a better outcome for FDS. For patients receiving treatment within 62 days, that improved to 65% in August, but was below our planning trajectory. But again, quite a significant amount of work has been done. I think the biggest challenge across the system, and I'm sure Adam will support this, is for Swift with the dermatology issues that they've had, but they've now got insourcing in. So we're hoping to see quite a marked improvement quite quickly on that. As I say, all 3 trusts are in a tiering regime, and that is proving to be valuable in terms of making sure that we share good practice and that we are actually bringing all of the good work into more of a coordinated approach. The other thing to say is 62-week backlog has reduced. and a lot of that is through the work that UHCW have been doing. That does mean that we'll see a reduction in their backlog, but we might see a deterioration in their 62-day performance for the next 2 months, but Region are aware of that, and it's the active encouragement of reducing the backlog that's important. And then finally, from a performance perspective, the only thing I just wanted to raise was at the end of August, we had an equivalent 34 adult patients with learning difficulties and potentially autism in a mental health setting, 4 per million population. This performance was above our planning trajectory, but there's lots of work going on in that area just to assure the board in terms of improving that target. That was all I was going to say from a performance perspective. Krishni, I'm happy to hand over to Jamie unless there are any questions specifically about performance.
Should we pause momentarily, Rachel, just to make sure rather than move on and come back to you? I was going to ask about 65-week elimination of those, but you've answered that already, so that's really helpful. I don't know whether to maybe leave the other question I had until Felicity comes in, probably talk about sickness, but just this may be too difficult a question to answer, but for somebody who doesn't have all of the metrics that go up to making NOF 4 in my head, I wondered whether we're clear what would change any provider from being NOF 4 to NOF 3. I suppose particularly how many of our providers are in NOF 4 because of financial override as opposed to performance. I think that's more the question I'm trying to sort of get my head around, because it just helps to put a bit of context. I don't know if you can answer that, Rachel. If it's in the too difficult box, it's fine.
I'll have a go. It's a really difficult question because all of our providers could improve and show improvement, but if everybody else in the country also improves and does more improvement, then it's really difficult to get a sense of how, where they are going to be in terms of that scoring regime. But you're right to say I think a significant impact to some of the scores for our providers in system has been around the financial situation they find themselves in. That said, I also think, and Andy may well want to come in also, UHCW, some of the data that was collected from UHCW at a point in time when where they were going through EPR may not be representative of them as an organisation, and I know they're doing a big piece of work to try and improve that data. So I think it's quite a complicated landscape to try and manoeuvre. So we have tried to have a go at trying to assess whether or not we think and we do think our providers will definitely improve the scores. And I think, I don't know, but I think providers may have been given some indication of whether they have made improvements. We won't know till that may be why Adam and Andy have got the hands up. We won't know till September as an ICB, but I don't know whether they've been given any indication already, because I know a lot of work's been going on.
Yeah. And and I'm asking really because obviously ultimately I see it as in our collective interest to have all of us rated more positively, because it all adds to the amount of scrutiny we have to manage and respond to. And whilst that can be helpful, and I think you've alluded to that already, Rachel, equally we want more autonomy, don't we, for all of us to be able to do what we think is locally the right thing for our population. And sometimes I think the scrutiny, it means that we're very focused on responding to that. So that's the reason for my interest in it. But I can see Adam wanted to come in, so Adam, if you've got any more interesting insights into that, it would be helpful to understand them. Thanks.
Yes, and I think we'll find out for sure in the next couple of weeks, and heavily caveat anything I'm about to say, but Rachel's comment, actually it depends a lot on what happens with the other providers regionally and in the country. From what we know though, in terms of the metrics that put George Eliot in NOF 4, we've made really significant progress over the last quarter, judged by where organisations were in quarter one, and that should be enough to get into NOF 3, but obviously George Eliot is capped at 0.3 because of the financial position. I think in terms of metrics, though, the most important headline is that in those key areas of UEC, RTT and cancer performance, George Eliot has made really significant progress over the last quarter.
Thank you, Adam. I appreciate that. Andy, please.
Oh yeah, thank you. Just to say, well, we've had no, or I haven't received no intelligence in terms of the potential Q2 scores. What I do know is that for all of the access targets, of which there are 9 plus 1 non-acute for us, we have improved. We've also improved on the financial position, as been mentioned, and on sickness. The data issue is particularly fed into the HSMR/SHIMI score, and so there's always a catch up there. And we also know some of these things are 12-month rolling average, so there is that effect on what happened last year. The one that nobody can explain to me, including NHS England, because we've asked several times, is the implied productivity measure. So who knows what that's going to say? There you go.
Thank you. Thanks, Andy. Mary.
So realistically, I'm not expecting a change in the Q2 data to be published next week. We are working on a plan of a change in our data in Q3. We've seen significant improvements in our 24-hour face-to-face contacts. But as Rachel said, depending on how others do, you just never know where you're going to land. And of course, there are 2 metrics in the mental health and LD bit that are annual, rely on annual surveys. So until staff survey gets done and community mental health survey gets published, we won't know where we're going to be. But for the ones that we can control, significant improvements. But whether that will lead to a change, who knows? But I'm not expecting a change in our segment for Q2 reports to be published next month.
Thank you, Mary. So I think it's important, isn't it, for members of the public to understand the relativity in the way that the NOF ratings actually are applied, which isn't quite the same as an absolute position that puts you into a different position. Russell.
Thank you, Krishni, and again, thank you for inviting me. This is the first time I've been to this meeting as well. I hear the point on relativity, but frankly, on behalf of the citizens of Warwickshire and Coventry, I want to apologise for the fact any of our providers are in the lower 25%, keep the maths easy, in being assessed nationally. We should have an ambition to be absolutely at the top of segment 3. We may have some financial challenges with PFIs and other things going on, but our ambition should be clear as an ICB. We want all of our providers to be absolutely at the top of segment 3, worst case, and that's what we should strive for. We need to be really careful in terms of our mindset, in my opinion, that we don't get into, well, we've always had these challenges and therefore it is what it is. And I'm optimistic about, with the new ICB leadership, we're going to push our performance standards higher, because we should be absolutely on the edge, all of us, on segment 3 at the very top, wanting to get into segment 2, but clearly to get into segment 2, you need to be in surplus.
Thank you, Russell. I think we'd all want to be absolutely aspiring to be better, wouldn't we? Because, and certainly in terms of public confidence in our services, I think that's really important. So getting underneath what we can do to make changes and move into segment 3 is a helpful thing, I think, for us to focus on and obviously work together on as well. So thank you for everybody's comments on that. Rachel, who were you handing over to? Was it Jamie next?
It's Jamie, yeah.
Jamie?
Yeah, good afternoon, Krishni. Yeah, so just picking up on the key equality points that we're raising here, the assurance framework that we use within the ICB is based on the National Quality Board standards and expectations. So that's a national approach. Probably the 2 things that I really wanted to bring out is that we had our first quality improvement group for George Eliot yesterday. I thought it was really successful, really well attended. We set out where we were and also the progress that has already been made. particularly in relation as far as the quality assurance framework is in terms of ophthalmology and radiology, but in a broader function as well. And also to know our engagement with the St Andrews adult mental health work that's going on, both the QUIG that's been established that is led by BSOL, but also our engagement with NHSC and with the police investigation that's ongoing. So it feels as though we are well engaged with those, but there's a lot of work to move forward. In terms of paediatric audiology at South Warwickshire, feels as though we're at the tail end of that. So we're just awaiting confirmation of NHSE, and then we'll be looking to step down the QUIG. So hopefully by the next board, we'll have taken paediatric audiology off. Happy to take any questions.
Any questions for Jamie? Harry, please.
Yeah, thank you. Thanks, Jamie, for that. There's quite a lot in this report, so I just want to turn to 1.8, where it says that there's currently one quality concern under intensive surveillance. Could you just highlight what that is?
Just yeah, so sure. It's the St Andrews. Sure, it's the St Andrews Adult Mental Health. So because it's got NHSE quality improvement programme, as well as the quality improvement group headed by BSOL and the police investigation, we've escalated that to intensive.
I see, thank you. And then the 4 concerns that are at an enhanced level, is there anything in particular you wanted to say about those, and is there a risk of those deteriorating further?
So those 4 are ophthalmology, primary care, radiology, and paediatric audiology. So as I said, with the paediatric audiology, we're seeing that coming to an end of its escalation, and we are expecting feedback which will allow us to reduce that to routine assurance. With ophthalmology and radiology, we're not expecting that to get worse, but it probably is going to take a little while for the QUIG to take effect on those areas, to the point that we'll be stepping it down. So although the QUIG's in place and some really positive work going on at George Eliot around those areas, I am anticipating that will remain escalated for a period of time. I think with primary care, there are only a small number of CQ practices that are actually escalated around I mean, it's less than 10% of our GP practices that have a form of escalation. There's no reason to believe that will increase. We provide support from the ICB into GP practices that are struggling. Some have been on that escalation for a long period of time, and we're hoping are coming towards an end. So I think as things stands at the moment, probably the risk that we're most removed from and concerned about is probably the intensive support of St Andrews, which is one of the reasons it's at intensive support, given that it's got it's got a regional and a national profile. Thank you.
Just reflecting on what Russell was saying earlier, I perhaps asked the wrong question, because obviously we shouldn't only be concerned with things that might deteriorate, but actually maybe the better question might have been when do we think those things will be out of intensive or enhanced and in a better place? And I wonder whether for future iterations of the report, just giving the board a sense of that and timescales that we're sort of working to, or target timescales at least, might be helpful. Thank you.
Okay, thank you, Harry. Picking up the point about the about St Andrews, I mean, we are as engaged as we can be for a query or a concern that is much broader than just Coventry and Warwickshire. So we sit on both the QUIG, we are fully engaged with the regional SOG, and we are as engaged as many other ICBs are in relation to that. But it is a major issue, and I can't see it coming off intensive. Certainly by I'll be very surprised if by the January meeting that stepped down from intensive, and it's with a provider that's had some problems. Yeah, this is not the only problem.
One's outside our gift, isn't it, Jamie?
Indeed,
we're
yes.
not within we're not within the control of that, but obviously aware of that one, having sat in the Northamptonshire ICB area for a little while. It's something that I think a lot of ICBs have been had oversight of, but certainly I think Harry's point about the other things, I think timescales are always useful to have. So thank you. Where we can provide them, it's certainly useful, I think. So thank you, Jamie, really helpful. And then is it over to Maddie next or
Yes.
Felicity? Maddie next.
Over to me for finance. Thank you. I'm pleased to be able to say that the ICB finances are in a relatively good position, and we are on track to deliver our 4th year of our statutory duties as an ICB. And in terms of our joint responsibility to break even as a system, we are currently forecasting that we will. However, it is worth noting we do have some significant efficiency still to deliver in Q3 and Q4. So there is some risk in our acute provider partner sector around efficiency delivery, potential industrial action and winter. Obviously, we are keeping up the Financial Recovery Board to keep on track of mitigations and remedial action plans to ensure that we keep that sort of grip and control for Q3 and Q4. The report, as read, concentrates on month 6, but we retain the relatively good system and ICB position as at month 7, which is currently just going through the reporting process up to NHS England. And our attention has started to turn to obviously planning for 26-27. The suite of financial planning products finally came out on Tuesday night from NHS England. So we have now been issued a 2-year allocation, and we will be therefore working towards submitting financial plans triangulated with activity and workforce for the 17th of December. There is some good news in some of Coventry and Warwickshire's allocation in that the recognition of our faster than all England average population growth is recognised. However, because of the convergence and distance to target calculation in that allocation, that's not fully recognised obviously in our 2-year allocation, but is tempered, and there are some offsetting parts of the calculation that mean we're not seeing quite the allocation growth that the underlying target would get us to. So we're working through the impact assessment of that, and we'll work through the assessment with our system partners as we go forward for the next month. So that's where we're at.
Okay, any questions or comments regarding finances and finance update? A lot of work to do, I think, Maddie, going forward, isn't it? Which is sort of links to what Becky was saying earlier and raised with Simon earlier, that we've got all of the medium-term planning and all of that to do alongside commissioning plans and transition, etc. But yeah, thank you for the update. If there are no comments on finance, then we will move on finally to Felicity. If you've got some comments, Felicity, you want to make?
Thank you. Just a few things to point out. So our vacancies for our NHS provider workforce remain fairly static, and at month 6 we were 151 whole-time equivalent below our plan. We have reset our workforce plan for H2, so we'll report against the revised plan at the next meeting. We're performing really well against our bank and agency reduction target. So for bank, we're at 14.8% reduction already against a 21% target. And agency, we're at 43.5% against a 47% reduction target. So really great performance against those reductions. Sickness is fairly stuck. It's at 5.89%, and it has been increasing month on month. That's fairly consistent with some of our acute and provider peers who are around 5 to 6%, but it's well above where we want it to be, well above our target. All of our providers are currently have enhanced health and wellbeing and absence management initiatives in place. And we have also reached out within the cluster to Wyre Valley Trust because they've had some success in reducing their sickness absence. So we've shared ideas with our provider colleagues. Vaccination rates are fairly mixed again in Coventry and Warwickshire. Vaccination of healthcare support workers is fairly mixed. So again, we are looking at recommendations as how we can improve some of our vaccination rates in some of our trusts that aren't performing where they would want to be at the moment. We know early analysis of the effectiveness of the vaccine is strong, provides strong evidence that it does protect our healthcare support workers and our patients and our staff. So it's important that we do continue to push that vaccination. In terms of the wider people plan, work continues on developing our plan. We've continued to roll out active bystander training, which has been well received. Our Health and Care Academy, for those who are not aware of our academy provides support into employment, education and training for people from disadvantaged groups. And we've had 252 positive outcomes so far this year, which is great news. We are continuing to expand our website. So we have our Your Nursing Career Here website. We're expanding that to wider workforce groups to our Your Career Here website. And since the last board meeting, we've also launched our T-level campaign with a video and associated collateral to encourage young people into health and social care careers. We've also been successful in a bid to support nurse prescribing in adult social care, and successful work is underway to identify suitable care homes to be part of that bid. So generally positive progress being made against all of our people promise themes. The areas we need to focus on are sickness absence reduction and, as I say, the vaccination rates. So I will just pause there, see if there are any questions.
Thanks, Felicity. I was only going to mention sickness absence because actually when chairs were together just having an informal catch up, it came up as an area of concern really, because obviously that has knock-on consequences on all sorts of other things, not least the care we provide, use of agency, and obviously financial implications as well. So good to know that we've got some well-being actions that are we're sort of picking up, I think, in terms of supporting people to stay well. And of course, part of that, although increasingly always difficult, is vaccination uptakes, isn't it? I don't know whether, certainly in my experience, it's become more difficult since COVID to get staff to engage in flu vaccine uptake. So that's proved difficult. But yeah. So any other comments or questions regarding any of the workforce aspects that people want to come in on? Okay, so thank you for Felicity for the update. So obviously we'll take the rest of the report as read, and there's lots of information in there. But as Rachel said at the beginning, so just really to highlight some key issues for our attention for the board. So thank you very much, and obviously there for our noting and assurance. Okay, we move on then to what I think is sort of the final section of our agenda, which is governance and assurance. So first of all, over to, is it Mark who's leading on the cluster governance update? So where are you, Mark? There you are, in the centre of my screen. Over to you.
Good. Yeah, this report just builds on Simon's earlier updates, giving more detail about the governance arrangements for the cluster as we get some Coventry, Warwickshire and Herefordshire and Worcestershire boards coming together. So the paper here sets out the composition for the Coventry and Warwickshire board, which will start meeting in common with Herefordshire and Worcestershire from January. We've been looking at aligning and streamlining the membership. So 4 executive and 5 non-executive members on top of the chair, reducing partner members from 7 down to 4 in each of the ICBs, and recognising those roles are discrete to the particular ICB rather than being shared across the 2 boards. The second appendix there sets out constitution changes which are linked to the above, and the board are asked to endorse that for submission to NHS England, because approval of ICB constitutions is in the gift of NHS England rather than ourselves. The following appendix then goes on to look at the committee operating model and terms of reference, setting out the 6 committees that are proposed for moving forward, which the Corporate Management Committee, Audit Committee, Remuneration Committee, Strategic Commissioning Committee, Strategic Finance Committee, and the Integrated Quality Performance Assurance Committee. The paper then goes on to set out the terms of reference for the first 3 of those today for approval, with the remaining 3 terms of reference to come forward in January once they've been finalised. So that gets the initial 3 committees set up and running, ready for the new year. And the paper also sets out the high-level terms of the high-level remit for each of those committees, along with transition arrangements and timelines. That, from a Coventry Warwickshire perspective, also means the dissolution of our ICB internal transition committee, which was set up as a time-limited committee to support some of the work moving forward to clustering. So in summary, I'm requesting board to endorse the constitution changes for submission to NHS England, to endorse the composition of the new Coventry Warwickshire ICB board, and approve the disestablishment of the ICB transition committee, and endorse the high-level committee structure and terms of reference presented today.
Thank you very much, Mark. So obviously, colleagues, we've had discussions about some of this through one of our development sessions, I think, and certainly some conversations with individual colleagues who may be affected as well. So hopefully what this sets out then is something that looks familiar to most people. Obviously, there is the detail of the constitution for our approval. I think it's fair to say, I think NHSE are the final arbiter on the constitution, so they will have to approve it, but it was obviously important for us to cite you all on what is proposed to be included on that, as indeed the terms of reference, which are obviously for committees that we will be establishing at this stage, although there's lots more work to be done, as the paper sort of highlighted. So what we want to do, and certainly conversations I've had with colleagues, is about just sort of trying to do what's absolutely necessary at this stage and maintain what we need to maintain for a safe transition, which I think allows us to get the right balance, really. So if there are no comments or questions, can I take it that colleagues are just happy to approve and endorse the certainly the 2 key the key things are the endorsing of the constitution, the new composition of the board, and then the approval of the operating model and the terms of reference and the disestablishment, which Mark highlighted. So I saw 1 thumbs up, but I'm assuming that in the absence of any comments, I've got thumbs up from everybody else as well. Is that okay? Great. Thank you very much. So Mark, we'll take that as approved. Becky, did you want to clarify something? No, you're just giving a thumbs up. Okay, lovely. Thank you very much. Okay, so that's approved, Mark. So we can move on to the final item, which is the committee escalation and summary reports from committees. So it's back to you, Mark.
Okay, thank you, Krishni. As you'll see in the papers there's quite a bit of activity been happening over the last period, with a lot of updates from the various committees. The only thing that I wanted to really pull out for highlighting was within the Audit Committee, the request for decision by board to delegate approval of the annual report and annual governance statement to the Audit Committee for agreement, as has been the case in previous years, just to streamline that process. But committee chairs may have other aspects they want to highlight from their respective committees.
Okay, so we are asked to approve the delegation of the sign-off of the annual report and accounts. Is everyone content to do that? So maybe approve that now, and then I can open it up to committee chairs for any other comments. Everyone content to support that? I think that's fairly commonplace to do. So we will confirm that. And I will open it up to our non-executive colleagues, or indeed, I think also Suki has been very supportively running, I think, Finance and Performance Committee for us as well. So happy to bring in colleagues who might want to comment or ask any questions actually about the individual reports from the committees. So start with Chris. Chris, please.
Thank you. It's not a matter of escalation, we've covered that, but it is a matter of awareness really. And I just wanted to record thanks again to the finance team in the most difficult times for the work they've done to make sure the implementation of the new ledger has gone as smoothly as it can. They've had a few bumps in the road along the way, which they're dealing with, but I just really wanted partner members to be aware that this continues to be a short-term challenge for the team, and there obviously may from time to time be challenges with payments being made as quickly as we normally would. I know the team are handling that proactively and communicating with suppliers and colleagues, but I just wanted the board to be aware.
Thank you very much, Chris. Maddie.
I just want to thank Chris for the recognition, and just to say, as a result of the hard work of the team, even though it's been incredibly difficult to handle accounts payable, we have actually managed to come within our cash target for month 7, which is a real testament to the team and sort of hard evidence of how hard they've been working to get those payments flowing. So thank you.
Thank you, Maddie. And I was going to ask, are there any kind of particular risks around cash, Maddie? But it sounds like you've managed those. So
we've put in a lot of workarounds to ensure it flows. So thank you.
Great, thank you very much. Okay, any other comments or questions? I think I just had one, if I may, and it was just wanted to clarify, and Chris, you may be able to answer this. There was something around an audit around care collaboratives that was pending appointment of non-executives. So Laura or Ali or others, I don't know whether it relates to care collaboratives or an audit, but I was just curious about that because it wasn't absolutely clear to me what was outstanding. So Chris, I don't know if you can comment on that.
Yeah, we have a piece of work in the audit plan which is looking at the governance, the overall governance arrangements for care collaboratives. Obviously, from our perspective, the important thing is for the governance arrangements to develop ideally in advance of any changes, clearly to ensure that the appropriate governance remains in place. And this is a piece of work that's part of our assurance process in relation to that. Rachel, do you want to comment about the timing, basically?
Yeah, I can do. So this is a piece of work that we do regularly, Krishni, in terms of the maturity of each of the care collaboratives. It's a self-assessment that they undertake, coupled with a piece of work that we do on external assessment of their maturity, and particularly with a view to moving to the next stage of their maturity. So we've paused that piece of work because we are doing a piece of work collectively across Hereford and Worcester and Coventry and Warwickshire to look at almost what would care collaborative version 2 look like, and what the journey would be to the next couple of stages. So we've just agreed we'll pause that for now.
That makes perfect sense. Thank you, Rachel, for that clarification. Chris, was there anything else you wanted to add? I'm sure that was fine.
No, that's fine. Thank you.
Great.
Yeah.
Super. Well, thank you very much. If there are no other questions or comments, I think that brings us to the end of our substantial business, unless Mark or anyone tells me I've missed anything. Mark, have I covered everything that needs to be done? I think I have, haven't I? So I can't promise I will do this often, but we seem to have finished slightly ahead of time. It may be a one-off. I don't normally well, sometimes I have actually found myself giving you plenty of time back. I'm sure you'll be grateful for it, but I thank everybody for their contributions. It was certainly incredibly useful for me to hear from so many colleagues to get to know some of the issues in a bit more detail that you're dealing with, but I really appreciate everyone's contribution today. And I just want to take the opportunity again to thank those colleagues who we mentioned earlier, for whom this may be or indeed is their last formal meeting of the board. I know we'll see them in the coming weeks before they formally step down, but I just wanted to reiterate my thanks, and particularly to recognise people's contributions in public, because I do always think it's important for us to do that as a board. So thanks everybody, and thanks for your contributions, and I'll close the meeting. Thanks. Bye bye.